can introduce Kathy?
No, I think if you can introduce, that'd be great.
Okay, great. Well, good morning, everyone, and thank you for joining our monthly SWASA rounds. It's my privilege this morning to introduce our colleague and friend, Dr. Kathleen Lumb, who's joining us from Prince Albert, Saskatchewan, early in the morning. Thank you, Kathy, for joining us so early. Dr. Lumb grew up in the Canadian West in Alberta, and after completing her undergraduate degree and Master's of Science degree, she attended medical school at the University of Calgary. She then joined the General Surgery residency program here at Western, and she was a true asset to our program. And I know Dr. Vogt and Dr. Leeper, who are also on this call, will agree with me in saying that we were so lucky to meet Kathy and have her as our trusted co-resident, a reliable colleague, and a really good friend. After residency, Dr. Lumb joined the staff at Prince Albert, Saskatchewan as staff general surgeon. She has served as the chief of general surgery there and practices both in Prince Albert as well as some rural outposts. She participates in the training program at the University of Saskatchewan as an assistant professor and trains residents who come up for community and rural rotations there. Following Dr. Lumb's talk, we will have a panel discussion on rural surgery in Canada with Dr. McIver and Dr. Glass, and I'll invite you to add any questions to the chat, and I'm happy to moderate that. So Dr. Lumb, thank you so much for joining us early this morning at 6 a.m. your time, and for sharing your experiences with the joys and challenges of community general surgery in an underserved population.
Well, thanks very much, Julia. And I'm really honored to be here and so happy to see some faces that I haven't seen for a long time at, the best residency program in Canada. And I'm very honored to share the panel with Dr. McIver and Dr. Glass. So Julianne, you're going to flip through my slides here. You can go ahead to the first one here. The first thing I'd like to start with is our standard land acknowledgement that we have at the University of Saskatchewan. So as we gather here today, we acknowledge we're on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nations and the Métis ancestors of this place and reaffirm our relationship with one another. You can go ahead there. So I just thought I'd throw up a little bit of geography for everybody. So Saskatchewan is a province that I did not know much about other than having lived next door for many years before I started working here. You can see that Prince Albert is right there in the middle of the province. It's about halfway up. We've got two large cities, Saskatoon and Regina being the capital. They're each approximately 350,000. The total population of the province is only 1 million. And with Prince Albert being there in the middle, we're actually on a dividing line. Pretty much everything south of us is farmland, and pretty much everything north of us is boreal forest and lakes and untouched wilderness and trees. If you look a little straight up in the middle of the province, kind of 3/4 of the way up, there's a town called L'Orange that we'll talk about, and I've got some pictures from there. Our catchment area for Prince Albert is most of the northeast portion of the province, and it's about 100,000 people is estimated. We're an hour and a half north of Saskatoon. You can go ahead. So I only have a few slides that have words on them. I thought I'd just introduce the community, and then I made this presentation kind of as an experiment with almost all pictures, and all but 2 pictures here are my own. So this is one that's not mine. Prince Albert is the 3rd largest city in Saskatchewan. Our slogan is the gateway to the north, which is absolutely true because we live on the North Saskatchewan River here, and there's only one bridge across this river. If you happen to come by Prince Albert and the bridge is out for some reason, it's an hour and a half's drive in either direction to be able to cross the river, and you have to go one way in the winter because one of them is a ferry that only runs in the summertime. What that means is almost all goods and people and traffic go through our city on the way to the northern communities here. Unfortunately, that also means some bad stuff goes, particularly the local drug trade. One other thing that's awesome about this area is we are 50 minutes south of the amazing and huge Prince Albert National Park, which is incredibly beautiful and tons of stuff to do. You can go to the next one. We have a population of just over 36,000, and it's a very young population. We have the largest age group being under the age of 14, and the average age in town is 37.7. It's also a bit unusual as we have a very large urban Aboriginal population. 44.65% on the last census identified as Aboriginal and 43% European. And then the rest is a breakdown of numerous other ethnicities. Unfortunately, it's not the most socioeconomic stable area of the country. We have the overall poverty rate being 19 to 24% and a child poverty rate of 28 to 35%. That's on the poverty index by Stats Canada from 2021 data. The second two statistics there I'm not sure of. They're older data from 2020. And at that time, they said the average household income was $74,000 and unemployment was 11.5. I'm sure those are different now, but I don't know which way they will have gone, up or down, or hard to say. Next. So that being said, Prince Albert is a fairly okay sized city. We have all the amenities. You can see at the top of the picture there is the North Saskatchewan River, and in that little curve of the river, the runway is where our airport is on the far side of the river. The city is built on the south side of the river, and we have all the usual amenities. We have a gorgeous art center. We have 2 rec centers with indoor soccer fields. We have a Walmart and a Rona and Canadian Tire, and we're an hour and a half north of Saskatoon, which has an international airport. Next. So as I mentioned, we do have a lot of issues here. As of this year, we are the 3rd in Canada for the highest rate of violent crime for any communities over 10,000 on the crime severity index score by Stats Canada. That's actually a win for us. We've been number 2 for many, many years. So when we saw this, we thought, oh, we're improving. But it's still not great, obviously. North Battleford routinely is number 1 and still is this year, but somehow Thompson, Manitoba managed to sneak into the number 2 spot. So 2 weeks ago, we had this awesome measure come out, which was a measure of the drug loads in wastewater, and we were found to have the highest level of cocaine, methamphetamine, and general amphetamines in our wastewater of cities across Canada. We are a city of conviction, as my realtor told me when I bought a house here. We have 7 correctional facilities, and the picture here is not mine. This is the federal penitentiary, just located on the edge of town. We have a female correctional facility. We have a juvenile detention facility, a couple of provincial jails, and a couple of remand centers in the area. And we have a lot of issues with drugs, gangs, and poverty. We actually have a RCMP unit here dedicated to gang related crime. Next. The last 2 slides with words on them. This is just a little bit about our hospital and the picture of the hospital there. It's 134 acute care beds. We have 8 ICU beds, small little emergency room, 18 beds with 2 trauma bays. We have 5 ORs. We do have a CT scanner, but we do not have angio-interventional or MRI here. With respect to staff, our emerge is usually staffed at all times between 1 and 4 GPs. We have 6 anesthesiologists, 6 general surgeons, soon to be 7 because we just hired a new one and we're approved for an expanded position. 4 orthopods. We have a few specialists in the other areas of surgery, and we have a radiologist in-house on weekdays during weekday hours. Next. Equipment-wise, we usually have about 50 units of blood, 32 of FFP. We don't carry platelets here because we don't use it fast enough and they tend to expire. We have 8 to 10 ventilators and maybe some extras after COVID in corners, and 1 C-arm. We do also train family medicine residents and medical students here. We have 6 family medicine residents in each year, and then usually about 5 to 7 medical students who do their entire clerkship rotation here. And the picture is aerial, and it's the bridge going across the North Saskatchewan. So looking from the north to the south. Next. So what kind of practice do we do here? This is a picture of me and one of my surgical assistants. Dr. Kemp is one of our local family docs. We took this because they gave him the short gown and me the long gown. So the really nice thing that I love most about community general surgery practice is the breadth of practice. So I get to operate on adults and kids and elderly people. We do a lot of bread and butter stuff up here, your usual appendix hernia, gallbladder, bowel obstruction, cancer cases. We also have the ability, though, to do some more specialized cases. So myself and one of the other general surgeons do breast surgery as well, and we're an outreach of the Saskatoon University of Saskatchewan program in Saskatoon. We have one surgeon who has extra training in head and neck, who does thyroid and parathyroid, so often hop in with him on doing some of those cases. We do a fair amount of trauma with our drug and gang problem, lots of stabbings, unfortunately more and more gunshots, and a lot of jail-related trauma. We also do all the endoscopy in town. There are no gastroenterologists, so we do both acute endoscopy for bleeds and things like that, as well as a lot of chronic stuff. And then we do lots of training of residents, lots of administrative work, and a few other things. Next slide. This is one of the other things. So we get to do field trips. So the top right corner there is the hospital in La Ronge, Saskatchewan, which is 2.5 hours north of us here. I am the surgeon that go up to that community. I usually go 2 days a month, and I do 1 day in the hospital I can do upper endoscopy there and some minor lumps and bumps procedures. And then I do 1 day in their clinic where basically patients come from all over the north to La Ronge. I see them, book surgeries, usually in Prince Albert or in La Ronge. We also have an outreach clinic out in Big River, which is just east and south of us. They don't have a hospital, but we do a clinic day there. Every once in a while, it's a little bit intermittent. And then the bottom picture there of the brown building is Nipawin Hospital. They've actually got an operating room there with some GP anesthesiologists. And so one of my colleagues goes out there usually 4 days a month, and he does some endoscopy and minor procedures, but with general anesthetics. So gallbladder, hernia repairs, that kind of thing. Next. So that being said, we do have a lot of challenges working in a rural location like this with a lot of socioeconomic problems. The top picture here is Little Red River Park, which is the largest urban park in Canada. It's got kilometers and kilometers of trails, which all become cross-country ski trails in the winter. And the bottom 2 pictures are my 2 favorite hikes in Prince Albert National Park. On the left is Kingsmere River, and on the right is the Bog Trail. One of the main challenges we have is recruitment and retention of staff, as you would expect. And I mean, that's true of every rural site across Canada, but it's even harder when you're in Saskatchewan and BC and Ontario are there, and most people don't really think Saskatchewan is a place they want to come live. One good thing we have working for us is we are a bit of a larger center, so we can usually have employment for people's spouses or children, good schools, that kind of thing. It's even harder in smaller communities like La Ronge, where they don't have a lot of additional resources and jobs that people can work. But it's been a challenge since I started here. We've had major trouble keeping OR nurses, physiotherapists, pharmacists. On the physician side, we've had major trouble trying to get anesthesiologists to settle here. We've been looking for an orthopedic surgeon for over a year. So anyway, it's always a bit of a problem. Pay scales are pretty high in Saskatchewan comparatively, but it doesn't seem to always attract people, even though we pay a bit more than elsewhere. So next picture. So we also have a lot of challenges in terms of getting patients to come see us. So we have many, many, many no-shows. And this is one of the very common issues in rural communities, but in especially ones that have such a large geographic catchment area. On the left here is one of the ski trails at Little Red. On the right, I always take my snowshoes when I'm working up in La Ronge because they have incredible trails up there. No-shows are not always caused by, patients forgetting appointments or not wanting to come. I'd say that's the vast minority of things. Weather up here is a major problem. We have many communities that are in our catchment that are only fly-in, so oftentimes the planes aren't flying. Or we have some that are on all-weather tracks, which are good for 3 months of the year, and winter, of course, they kind of shut down. We also have issues with transport. Sometimes it's just that the taxi doesn't show up to pick the patient up to bring them down for their appointment. Next slide. We also have issues. Sometimes patients will have problems with childcare. On the day of their appointment, suddenly they don't have anybody to take care of the kids, or elder care. They can't take care of the family. Or other social issues that can certainly impact as to whether or not people can make it down. The next 2 slides are pictures of our winter fair here in Prince Albert. We have a sled dog race that's a pretty competitive one. This is a team from Germany. They use it as a prep race for the Iditarod up in Alaska. So they actually run from Prince Albert to La Ronge, which is a pretty incredible trip for the dogs. Next slide. And we also have this amazing competition that's called the King and Queen Trapper competition. So there's a male and a female competition, and it involves 6 or 8 events, I think, including log sawing. You have to portage a canoe, and there's even an animal call competition as part of this. So it's pretty entertaining to watch if you go. Next. One of the other issues that we run into in getting patients booked can be a language barrier. Here in Prince Albert, we have three main groups, I guess, that we work with primarily. So on the left is the Canada Food Guy in Dene. On the right, we have a stop sign in Wood Cree, and we have a large Métis population as well. It can be a language barrier. A lot of the older generation don't speak English fluently or don't speak it at all as possible. And the other thing is some communication issues. So sometimes cell phone service is out or somebody's cell phone quits working, and it's often very difficult to get in touch with people. So often we're liaising through the little local health centers in most of these communities, which are often staffed by nurses or nurse practitioners only. Next slide. This is a picture of the floatplane base in Orange. This is from my hotel room when I go up there. I was asked to talk a little bit about some special considerations with First Nations populations. And that's been one of the most amazing things about my job is getting to learn more about these incredible communities. One of the things that I admire most is how connected our patients are to their families. Usually people have large families who are often very involved in their care and want to be present. So one of the things our hospital does is tries to make accommodation for that. So we've opened up our rounds in the morning to as many people as want to come. We accommodate large rooms where we can do family meetings, of course, with patient permission. And we're careful to sort of diagnose or designate one person as the contact point, because otherwise you're going to have cousins and aunts and uncles phoning for information at all times. I think it's critical for healing that patients have access to family support, and it does seem to help significantly with people getting better faster. Next slide. On the left is the first building in Saskatchewan. That is the church in Stanley Mission, which is north of L'Orange. It's on a little island. You have to take a boat to get there. And on the right is just a picture from camping in L'Orange one night. We have issues as well with certain medications not being covered for our First Nations patients. For example, ketorolac, for reasons that I do not understand, is not covered. So many of our patients have medications adjusted just based on what is going to be covered for them or what they are going to be able to afford separately. We also have many patients who are deeply connected to the land, of course, and subscribe to traditional healing methods, whether that be herbal supplements or herbal medications, traditional ceremonies, and traditional people involved in their care. So again, that's something we accommodate for in our hospital. We have areas for smudging and for group and community gatherings that may help patients with their recoveries. Next slide. This is a picture just south of Prince Albert flying towards Saskatoon. The last thing, I would be remiss if I didn't talk about the trauma and the racism that have been experienced over the years by our First Nation population. I just want to say I don't presume to speak for the population. I'm not First Nations myself. So it's critical, in my opinion, for all healthcare workers to recall at all times that this is a major issue, remains an issue throughout the Canadian healthcare system, both with direct racism and trauma, as well as with systemic issues that affect our patients. And I think it's a requirement of all healthcare workers that you maintain knowledge of what's going on, make sure you're doing your equity, diversity, and inclusion training, understand that your patients may have had very traumatic and very upsetting experiences in the past, which makes people reluctant to seek out care. And, you know, calling out racism and being an ally whenever it's encountered, whether it be systemic or whether it be direct person to person. So it's critical to keep in mind that this is happening and that you are one of the people that can speak up for people and reduce that in our system if at all possible. Next slide. Okay, so I was just going to talk very briefly about a couple of cases that might illustrate things. This is the Nut Point Trail in L'Orange. If you go over this little hill, there's a giant lake, and it's a one-day hike-in, camp, and then you hike back out. The first case I'll present is a 16-year-old male that came to me last year with a gunshot wound. He's from one of our northern communities. His community is about 2,000 people, and unfortunately has a lot of socioeconomic problems, a lot of gang violence. The young man came in relatively stable. He was flown in, it was during the summertime. But as I was seeing him, he started to deteriorate. So his heart rate was going up and he was becoming unstable, hypotensive. So took him directly to the operating room. He had an entry wound in the left lower quadrant, came out, actually the bullet you could just feel under the skin in the right upper quadrant near the rib. Trauma laparotomy, he had one mesenteric tear that was bleeding quite significantly, that was oversewed. He had numerous in and out, sort of through and through injuries to the small bowel in about 100 centimeter segments. So I did a resection and primary anastomosis for that. And then a through and through to the colon and the hepatic flexure that was repaired primarily. He had a small liver tear that just was treated with cautery. And he actually did very well after the operation. So the operation was awesome, super fun as a surgeon, but the big issues arose when we tried to get to the point where we could get him discharged. So the issues with this young man, he's living with his grandparents in his small community, and he's involved in gang violence at the age of 16. Unfortunately, he didn't, he also had some mental health issues that were not being treated very well in his community. So we wanted to get counseling involved and see if we could get him out of the gang life. The biggest problem is he can't go back to that community. Everybody knows everybody. Everybody knows where he lives. He's kind of a marked kid. People are out to get him at this point. So finding a location for him to go is a major undertaking. And thank goodness we have excellent social workers here. But he had one sister in Regina who had some of her own issues and wasn't able to take him in. And when we finally found a place for him to go at one in a different, smaller community where he had some other family members, unfortunately, it turned out that the only counselor in town was his cousin and knew him very well. So trying to get the mental health support he needed was also a major problem. We try things like group homes for pediatric patients, but unfortunately, they all have humongous wait lists. So this young man ended up spending an additional 2 weeks in hospital while we tried to find a disposition for him. I don't know how he did afterwards. He missed his follow-up appointment, and I hope he's doing well, but really have no idea. Next slide. These are some of my awesome colleagues. So on the left, there is Dr. Andre Grobler. He's one of our local family doctors and also does some endoscopy. And on the right is Dr. Brenda Hookinson. She's also a family doctor and has helped as a surgical assistant for many years. The second case I'll present is a 65-year-old female who also comes from one of our smaller communities in the north. She presented with a small breast cancer, so a 1.5 centimeter lesion, biopsy proven in Saskatoon to be breast cancer. And what I wanted to point out with this case is it's a very standard common case here. Saskatchewan has the highest mastectomy rate of any province in Canada. And we've done some pretty extensive looking into why that is the case. I'm on the provincial working group for this. And part of it is that options sometimes are just not available to people. So for this lady, she's 65, she's caring for 2 small children, her grandchildren, and also her husband's not well. So she's the primary caregiver for him in a small area. Prince Albert, we are able to do some chemotherapy here. Usually we have the patient seen by the oncologist in Saskatoon, though they often will make that a teleconference visit, so they don't have to go all the way down there. But we cannot do radiation. That is only available in Saskatoon. We do not have plastic surgery here. So if the patient is unable to spend time in Saskatoon due to obligations in their home community, unfortunately, that very much limits what type of treatment they are willing to take. So we end up with a very high mastectomy rate, as was the case with this lady who would have been ideal for a lumpectomy. And that's not uncommon around here. So next slide. All right, last couple pictures. The bottom one is just to the west of town, kind of heading towards Battleford. And that's my little plan flying around in. Next slide. You get to do lots of awesome hobbies when you work in a small place. So this is my other hobby. This is one of our team cattle penning events and also a ladies trail ride one summer. And next. And this is my last slide. This is one of my favorite spots to sit and contemplate life in Prince Albert National Park. There are amazing things and amazing people that you meet working in a small community. Lots of challenges, but I wouldn't do anything else. If anybody is interested in knowing more about the community, or if you're interested in doing a rotation with us up here in Prince Albert, we can often help with housing. You're welcome to contact me. Christine has my email address, and I'd be happy to talk to anybody. Thanks so much for having me. Looking forward to the panel discussion.
Thank you so much, Kathy. I'm just going to stop sharing. And I'll invite our two panelists to unmute and share your video. Alrighty. Thank you so much, Dr. Lumb, for sharing your experiences and those amazing photos. And I forgot to mention at the start what an accomplished both equestrian and pilot Kathy has become and is since she's been up in Saskatchewan. So I'm now going to open up to our panel discussion on rural surgery in Canada. We have, in addition to Dr. Lumb, two panelists who many of you know very well joining us. This is kind of a past, present, and future type of panel, although I don't like the past part, so I apologize, Dr. McIver, for that. So our two panelists joining us first is Dr. Angus McIver, who started his practice in Iqaluit, and throughout his practice did many remote locums in the north, even through COVID. And Dr. Lindsay Glass, who is embarking upon her career as a community and rural surgeon and is already making a name for herself on the KEGS Committee in Rural Surgery and winning awards for her advocacy on the future and present of general surgery. And then, of course, Dr. Lumb, who we just heard from. So please feel free to unmute and ask a question for the panelists or put it in the chat, and I'll moderate those questions. So perhaps we'll start by opening it up to the three of you. If you maybe want to comment on your personal motivations for pursuing rural and remote surgery in Canada, and how your training prepared or didn't prepare you for any surprises that you found when you embarked upon your careers.
Well, I can start off. Can you hear me okay?
We can, yes.
Okay. My first taste of the North was when I was an intern, and I went up to Moose Factory as a medical resident, because Western had the kind of the obligation to provide a medical resident full time throughout the year, and they were short for a month, and so I grabbed a chance. My internship was half medicine and half surgery in those days. And that's where I got bitten. And then I think probably in my third year, I really couldn't see myself in an academic kind of practice. You end up doing something to fit in to where the need is in the academic center rather than what you really want to be doing sometimes. And so we ended up, after I had done some extravascular, we ended up going to Inuvik for 2 years. It was interesting because we were up there while another classmate of mine with the same aspirations or whatever went to Frobisher Bay, which is Iqaluit now. We were both up there for a couple of years. And once you've been bitten, you know, you just have that attachment out of sympathy. You see the hardships that people have to endure. It doesn't seem fair in many instances. But the only other thing I would say is that there are a couple of issues. One is, you know, how do you equip yourself to train? And of course, a lot of that depends on where you are. Kathy's in a spot very comparable to Stratford, other than the surrounding catchment area, about the same size, the same complement of specialists and all that. So there's a lot of stuff that you don't really need to do. But on the other hand, there are many other places where you have to extend yourself. And so that begets a bit of an issue. How do you train? How do you get that training that you need? And that might be a topic of discussion, the avenues that are available. You know, training on the job works in South Africa. It's great, but we're running out of South Africans because I don't think society tolerates that bush surgery training methodology any longer, you know, because there's a lot of roadkill. on the highway to competence. So we need to develop or secure good methods of training kids that want to either test the waters or make that commitment right up front. You know, there's some people that will have those aspirations early in their residency program that may even come into surgery, and that's what they aspire to do. And there's others that the light may go on later. And then finally, there's old farts that as they're slowing their practice down, they may have more extended skills than the younger people coming in. And it's a good way to give back a wee bit.
I can speak to
Dr. Lumb?
Oh, sorry. Go ahead, Dr. Lumb.
Yeah, I don't know that I have too much to add. You know, I was so lucky to come to Western for my training. Not only are there excellent teachers there, but that third year, what I did with it is I went all over the place and did rural community placements. So I did Chatham, I did Owen Sound, I came out to Red Deer, and then I did a couple of more academic center posts, but general stuff. So I did Sir John King Calgary, and I did hepatobiliary in Calgary as well, just to kind of give myself as broad an experience as I could, sort of setting up for a general rural practice. Yeah, I don't know what got the bug for me, because I never really grew up in a smaller place, but boy, you know what? I think what it was is I wanted to do everything. I liked doing everything, and I liked treating kids, and I liked treating cancer and all those things. And there is no other way that you're able to do that in today's world. So.
Dr. Glass, do you have any comments on what drew you to the practice you're about to embark upon? And
Yeah,
we'll talk about how to best train residents for their future in a little bit.
I'm sure most of you know that I am not from a city. I'm from a small town, and I went to NOSM. So my experience as a medical student, I was up in Temiskaming Shores, where there's a solo practice surgeon there, and saw the incredible variety which he was practicing, and also recognizing the need in these small communities. So the scope of practice, my background coming from a small town and wanting to contribute to a small community, is what really drew me to rural surgery.
I'll ask one more question, then I'm going to go to the chat, because I think we've just touched upon something interesting by all three of you in terms of recruiting and sustaining a workforce in rural communities. What's the best way to do that? To recruit people to elective experiences that might allow them to catch the bug, or to focus on local kids in high school or local kids who've gone to university who perhaps might want to come home and practice in rural communities? What's the best approach here to building a stable workforce in smaller communities?
Yeah, well, I can speak a bit to Saskatchewan. You guys are in Ontario, so you already have a little bit of a leg up on us. Most of us think. Usually people who come here from farther away want to move either immediately to BC or Ontario. I think all of those things are important. We've got adequate proof that recruiting medical students from smaller communities translates eventually to them going back to their communities in whatever specialty. So that is one thing. The University of Saskatchewan actually holds 25 seats for students from rural areas as best we can. And it's definitely translated into more physicians going to smaller places. Exposure during training is critical. One of the problems I see with the program here in Saskatchewan is in the general surgery residency, they're required to do 3 months of community practice, but most of the time the residents go to Regina, which, as you know, is a city of 350,000 people and is in no way a community type of practice. So it's a little bit hard to get an idea of what you're getting yourself into if you don't get exposed. So we do take residents on elective up here. That was certainly a factor for me going to a smaller location. Those are the main things. The other thing though is I think when you're recruiting somebody, you do need them to know what they are getting into. I mean, I would prefer to have somebody come here and do a locum prior to signing up so that they don't immediately determine that, okay, I can't stand living in a small place like this. I got to go somewhere bigger. And then you've got this constant turnover of people. And then of course, remuneration, you know, making sure people are supported in their community, making sure they have access to MOAs, all of those things are important as well.
Thanks. So a question in the chat from Dr. Brackstone. Since there are so many surgical needs in these communities, how comfortable do you become performing procedures that you may not have learned during residency and may not end up doing in very high volume and yet you need to do since you're the only surgeon there who's able to?
Well, I think it probably depends a bit on your age and your previous exposure, because you can recall things if you've actually done them as a resident. It's better than nowadays going on YouTube and think, oh, maybe I can do this. But I think you have to be honest with yourself. Can I do, back in the days before endoscopic urology, yeah, I'd seen and assisted that ureteric stone open, like this is 40 years ago. And those things come back to you. They're basic techniques, that you've learned when it comes to maybe stretching outside of your so-called comfort zone, which everyone seems to embrace these days as an excuse for work-life balance or whatever. But there are times that you're just uncomfortable, but you have to be comfortable being uncomfortable sometimes. That's just part of it. And there may be circumstances that you really have very few options. In the emergent case, like a gunshot wound that Kathy was saying, they're not going to be transportable. But on the other hand, some of the stuff that's second nature to you, like appendixes and gallbladders, in places where the resources are strained or you've got major medical comorbidities and no backup, you can load up an appendix and a gallbladder with antibiotics and get them out on the next plane. It's not the life or death emergency that our grandparents used to tell us, they just about died before they got their appendix out. Not so. There are other things, though, that your practice will be modified compared to what's going on in your community, depending on the comorbidities of the population base, and what may be a guideline. I gave Juliana an example, for gallstone pancreatitis, for example, in a isolated community. We know the CAG's guideline is that as long as their enzymes revert to normal, get the bag out on the same admission and do an ERCP or intervention on demand, because only about 10% of them will get into trouble later on. Well, you don't want somebody to have a recurrent episode of cholangitis when they're 400 miles up the coast or something like that. So on those instances, I would do, for example, a routine cholangiogram, even though routine cholangiography isn't recommended. This is for gallstone pancreatitis, mind you, not just a gallbladder. Because if I identify a stone, I don't need to do a common duct exploration if I'm doing it laparoscopically. But I would make it my business to make sure that person gets sent out within the next 2 or 3 weeks or something and get that ERCP and stone extraction done sooner rather than waiting for something to happen. That's just one small example. Another example of how you might have to modify your routine in a place like Moose Factory, where there's an 80% lifetime incidence of diabetes and obesity. And at least a lot of the people are walking around with elevated creatinines. You might have to temper tailor your no pun, Brian, your procedure, doing an ileostomy, which, you get high output renal failure in a place that has no dialysis, no support, and then they're 200 miles up the coast. You might either not put them together primarily, do a Hartman's or something without defunctioning them, or if you did defunction them, you might do an old-fashioned transverse colostomy, because they're not going to get into high output renal failure post-operatively. I have personally seen a couple of instances where someone gets a bump of 100 in their creatinine, they're already elevated beforehand and after a couple of bouts. And then there's the other issue with stomach care and the rest of it. So there's a lot of these logistics that temper your actual decision-making intraoperatively.
Yeah, those are some fantastic examples of special considerations. In terms of that comfort with discomfort, or discomfort or comfort with uncertainty, we've got a real mix on rounds this morning of practicing surgeons and trainees. That discomfort, and I don't know what to call it, the bravery to decide to go and do some rural locums if you're in practice or you're embarking upon practice, or to make the leap and go to a community that's either underserved or you're not used to a community of that size. Is that something that is kind of nature or nurture? Is that something that anyone can do, or do you think there's a particular personality that's better suited to going to rural locums or to starting a remote practice?
No, I think anybody could do it. I think you just have to be adaptable. That is the number one thing for working in a small location. You have to be flexible, and you have to be willing to MacGyver stuff when you don't have the equipment you need. And you have to, as Dr. McIver says, become comfortable with being uncomfortable. One thing I'm very fortunate in is that I'm in a big enough center to have some other surgeons with me, and they are excellent at coming to help out or assist if we do have trouble. We had a choledocoscope which broke in the first 6 months I started working here, and we have not been able to afford another one for our hospital. This is one of the things I didn't get to, but resources are not only scarce for patients, but also for small hospitals. And you're often making decisions about, does the urologist get a new cystoscope, or does general surgery get a new Geiger counter for breast surgery? It's always these, penny pinching measures. I think anybody could do it. You have to be, again, adaptable. You have to be willing to live in a small place. Locums is certainly an excellent way to find whether this is something that's for you. But I have to say, it is awesome. I had a 95-year-old lady with a big skin lesion on her forehead. I said, oh yeah, it's going to need a flap of some kind. I'll send you to Saskatoon to the plastic surgeon. She said, dear, I'm 95 years old. Just do it. So I'm actually very thankful for YouTube in general. I looked up how to do a free flap. It went great. It was super fun. I got to learn stuff. Yeah.
Dr. Kittmer's added a comment in the chat about the same, about being able to call or video another surgeon in while you're operating as well, which I think, I'm not sure if the three of you have done that much, but that's another advantage nowadays of the tech that we have.
Well, I can speak to that. I remember a little kitty in Stratford, which isn't, it's rural, I guess, by London standards, but bleeding to death with a Meckles, and I phoned Dave Gervin up. And I said, Jesus, Dave, I don't know what I'm going to do if there's no Meckles here. This is before imaging and stuff like that. And we went ahead and it was a 2-year-old. Did the Meckles, and then I phoned Dave up and I said, Dave, really, what if there wasn't a Meckles here, what would I have done? He said, oh, it's okay. I was pretty sure it was going to be a Meckles. So yeah, there is that phone a friend, and it's, you've got your friend on YouTube, but you've also usually made links with people in tertiary places, even no matter where you go in this country. In Iqaluit, we could always get a buddy in Ottawa. In Moose Factory, Kingston is their main out point, and Sioux Lookout, it's usually Winnipeg and Nunavik. It wouldn't usually be Yellowknife, it'd often be Edmonton. But that's been a big shot in the arm, particularly Zooming like this kind of. But you know, phone call was always, and that buoys your confidence up too when you've bounced it off a colleague.
A question from Dr. Leslie. And smaller communities with 1 to 2 surgeons, they have a great challenge with locums. What's the solution?
Well, I can tell you here in Prince Albert, we have a couple of communities that have 1 to 2 surgeons. In Melfort is Dr. Lassobekian, who actually was the KEGS Surgeon of the Year a couple years ago, and he's a solo practice. He also does ERCP there, which is really unique because we don't have that here in PA. You know, what happens if he can't find a locum, which is not at all uncommon? Patients get routed to Prince Albert. So basically, here we are close enough that we can take those patients. Let's say you're in Inuvik. There are no general surgeons up there currently, but there are, you know, lots of family doctors. Honestly, if there's nobody and you can't get anybody, people are being transferred out. There was a case in La Ronge. We have a number of South African trained physicians up there. They had an emergency C-section in a snowstorm in February, baby and mom's life at risk. And basically they did a C-section in their emergency department under propofol sedation with an anesthesiologist on the line and one of their very solid, very amazing South African trained physicians. Mom and baby did well, and we've actually worked up a protocol in case that happens again in a smaller area. So yeah, I mean, you're kind of up the creek if you can't find a locum, and they are hard to find. There are not a lot of general surgeons looking for locum positions, and more rural positions are opening up. I see every day, you know, we've got positions in BC and Alberta and Saskatchewan, and I'm sure in the East as well. So I think less and less of us are going to be locuming.
Dr. Gray.
Yeah, thanks. Kathy, nice to see you again. And I'm surprised you live in Saskatchewan and you're flying around in a low-wing aircraft.
Yeah.
That's not right. I think there's supposed to be high wings out there. Anyways, nice to see you. I have a question for all three of you. And with respect to what Tiffany said about being uncomfortable out there, and I get calls all the time. It's like, I'm not comfortable doing this. I'm not comfortable doing this. And you have all done, after your residencies, you've all done other specialty work, tailoring your needs to your communities. Do you think that in Canada, we need a residency program somewhere that tailors to non-tertiary care center training? Or do you think we have our residency programs, and if you're going to go work out in the community, you have to go and tailor your needs after that as sort of almost like a fellowship in what your community needs? But do you think somewhere in Canada we need a community surgeon residency program or not?
Daryl, that's a good thought. In Australia, they have a separate fellowship of rural surgery, so you stream into that. But I do think the teaching centers need to step up and develop programs, because in coordination with some supervision from the college, don't let it fall into the hands of the CPSO or these other people that make arbitrary rules on how many C-sections you need to do to be competent. You know, I mean, for example, I when I was done, when I was doing vascular, I had classmates that were final year residents in OB-GYN, and I said, next time you got a section, give me a buzz. I knew I was going up to Inuvik, and it was towards the end of the year, May and June, and it was quite, you know, the OB residents had done enough sections that I wasn't cutting their grass or anything like that. and I did a half a dozen, and I was good to go. You've got transferable skills. And just on that note, I would say that you do have to go outside your comfort level way into other specialties, because the emergencies that are going to get you into trouble are generally, I found the acute emergencies were almost all, or 80% at least, were obstetrical gynae emergencies, either crash section, postpartum hemorrhage, or that needs a D&C. Like how many of us have done D&Cs in our training? You know, an ectopic pregnancy. Those are the things that are going to kill people. The appendixes and the gallbladder, as I mentioned before, you can load them up with antibiotics and turf them out. But so we do have to have somewhere in the training program some kind of a module. I was on the Royal College committee, and it didn't go anywhere. We're trying to establish some kind of guidelines to get something, you know, say a 6 year, 6 week, 6 month, 3 to 6 months rotation where you could acquire these skills, and better minds than me could detail these are the procedures and skills that are essential to go into a smaller place. You know, go into a place like Stratford or even Prince Albert, you've got backup in the subspecialties, and you've got colleagues. But when you're on your own in the middle of nowhere, you know, you're all the patient has. And so it behooves you to upskill yourself for these critical situations that'll come in.
Lindsay, do you want to comment on what's going on at the level of CAGs? And obviously you yourself are embarking upon some obstetrical training before you start practice in the spring. I'd love to hear your thoughts.
There's a couple of things. So first is, like, in the US, there are rural track residency programs that are set aside for residents who are interested in pursuing rural surgery. And there's a lot of research that has gone into that to determine whether or not these residents are coming out with a high enough volume of cases in general surgery to actually create competent general surgeons on top of being rural surgeons. And they have been overall successful. So seeing a similar program in Canada would be excellent. Some of the smaller programs, for example, the Awesome General Surgery program does an excellent job of training rural surgeons, and other smaller programs are very comparable. In terms of, you know, right, as you all know, I'm in a fellowship program right now, learning extra training in hand surgery, and we'll be obtaining obstetrical training in Ottawa in the new year. I think that, you know, it's hard to actually train yourself in the skills that you need until you know what your community needs. So, for example, if I was going to a different community than Parry Sound, I would not need to know all the hand things that I'm learning, but maybe I would need to know how to do cystoscopies and stents. So, you know, I think that it would be important to have the knowledge of where you're going, and highlighting the importance of early recruitment. The transition to CBME in Canada, I think, is a huge positive for residents who are interested in rural surgery, because at that point you have a general idea of where you'll be going and able to tailor those skills. And academic centers need to step up and be ready to help train general surgeons going to rural communities. I mean, the Hulk group has been absolutely wonderful, but you know, it would have been easy for me to get my obstetrical training here, but they didn't have the volume for me, so I have to go to Ottawa for a month and further delay my entry into practice. So ultimately, that's to say is that it needs to be, it really needs to be tailored to the community that you're going to. And then with CAGs, we're doing, I work with the Rural Surgery Committee. There's a lot of work on developing continuing education opportunities for rural surgeons and community surgeons and academic surgeons who are interested in pursuing or going and doing locums in rural areas. For example, there's a C-section course. We're working on a urology course to really encourage and give opportunity to academic surgeons who wish to, academic surgeons and residents who wish to go and work in these smaller communities and make people a bit more comfortable with those emergencies that Dr. McIver brought up.
We've got 2 more questions in the chat, and then I think we'll cap it there. So I'll go to Dr. Taylor's question. for Kathy, do you actively attract surgical residents to Prince Albert or only students? And why the lack of orthopods when there are so many licensed orthopedic trainees looking for jobs?
Yeah, so
That
we do.
dovetails back to retention.
Yeah, for sure. So yeah, we do try and attract surgical residents. Part of the problem is in Saskatchewan here, their residency program has developed to the point where Regina actually uses them as a pretty reliable source of labor down there. So they all do a rotation in Regina, and finding time for them to come to one of the more rural sites is a little bit difficult. We have a few other sites around the province like Moose Jaw, Battleford, Lloydminster that have a few general surgeons, so they can also go to those communities as well. And it's not a very big training program, and it's the only one in the entire province. So, you know, we get the odd student through, and that has been very successful for us in terms of hires. So our last hire was a student who did a residency elective here with us, and then eventually chose to come back and work in our community. I don't know why they've had such trouble with orthopedics. I wonder if it's leading back to that question of being comfortable in a small community. You know, we have really excellent remuneration for orthopedic surgeons here. It's a good general orthopedic practice. They do, again, a rural kind of practice with kids and adults. And they've just had major trouble. And the one person they've just attracted is an international graduate who's never worked in Canada before. So I don't know, it's been posted for literally years. They've interviewed a few people over the course of the years, but just had major trouble actually getting somebody.
Last question, which will take a few minutes, and I'd really love to hear from all three of you, because I think you all have very unique perspectives on this issue and personal perspectives on it as well. If you all want to comment on the role of the GP surgeon in rural and remote communities. So GPs being trained to do surgery, whether it's locum or full-time in rural remote communities. Lindsay, maybe I'll start with you in terms of the position of CAGs, and then Kathy, I know you have experience with working with them and training them, and Angus, your experience as well throughout your career and where you see them fitting in. Lindsay, do you want to start?
Sure. So from the CAGS Rural Surgery committee, we're overall very supportive of this. Ultimately, there are areas in Canada which cannot sustain a general surgeon's practice. And there's areas in this country that, for example, in certain areas of BC, they have a 14-hour ferry ride to get to the community, or way up north, for example, Inuvik, which is generally supported by GP surgeons. That's an enormous area for distance to travel for patients. So ultimately, I think we need to be supportive of these practitioners who are being brave enough to provide care in any austere environments, and provide care for patients to stay in their communities in order to, for example, something that isn't, they're not doing complex oncology cases, gallbladder, more often it's a hernia or an appendectomy, and then having the skills in the community to do a damage control approach. They're not doing the complex reconstructions. If you have a laparotomy, you can take out a spleen and then transfer them. These patients are not transportable. So it's areas that are trying to provide a service that is within reason, and then have the skills in the community to save a life.
That's interesting. I think that's actually quite a shift in CAG's position of through the years.
At least the rural surgery side, we're very supportive of it.
Dr. McIver?
Well, I remember initially CAG's position was generally negative about GPs doing surgery. But I think they did shift about 10 years ago to look at more of a procedure-based practice. You know, I do this. I'm not, the whole thing of a GP surgeon just kind of leaves me a bit cold, but a GP who is able to do some surgical procedures, I think is great. You know, you can train a GP to do even elective stuff like a carpal tunnel. That is not going to, it's going to be a big money saver for the health authority and the government to have this done in a close to home. let alone the logistics of having to go from, say, Rankin Inlet all the way down to Winnipeg 2 or 3 times for nerve conduction studies, and then you meet the surgeon, then you go down and have it done, and you need an escort each time. All this crap can be circumvented with actually sometimes visiting surgeons. And what I would say is there is a slippery slope here. You know, it's sooner or later you'll get into a situation where you have to be pretty cognizant of what you can do and what you really shouldn't be doing. As I had mentioned before, appendixes and hot gallbladders, they can be loaded up with antibiotics. And if there's, you know, unless it's a straightforward teenage kid or something like that, if there's anything that might smell of something that's just outside the ordinary, you can always send it, even if it's later on. There are some things like gunshot wounds that you may not be equipped to even deal with. Even damage control, you could, you know, there may be some consequences of not having a surgeon there. The other thing I do feel sometimes happens is you have a GP who can do some surgical procedures, and well, you know, we have to keep the OR busy, so let's do hernias. Well, I'm sorry, I'm not going to have my hernia done by someone who does 2 or 3 a year. There was a gal that gave a presentation. I think she was from, I don't know, Norway House or someplace out west, and said that she had done 3 hernias in a year. Well, I'm sorry, that's just not good enough. This is an elective procedure 99.9 times. The strangulation cases could be dealt with in a separate teaching, you know, some type of damage control, free up the bowel or something. But I think just to be doing routine procedures. And the last thing I'll say is, you know, don't pad your portfolio with something like endoscopy, because unless you've got advanced skills, bleeding varices and injecting ulcers and clipping vessels and stuff like that, that's going to take a little bit of training to get all those things under. And not only that, but even surveillance for colorectal neoplasia needs to be looked at critically. There's no reason you can't have a top-notch endoscopist come to an isolated community for 3 or 4 days and bang through a dozen or 2 scopes, and there'll be high quality exams. I have personal experience seeing bad quality exams. That's all I'm going to say. So just padding your daily routine with endoscopy is a way of justifying your, you know, and I've seen other GPs that do surgery that almost have a referral practice. They don't even do the regular GP stuff. You know, there is a place, Nunavut maybe being the only place in the territories where that could fit, and as well as northern BC, northern Alberta, northern Saskatchewan, possibly, I don't know, but by and large, everything east of Winnipeg, it's a no-go. I can't see any sustainable, you know, and as I said before, running out of South Africans.
Dr. Lumb, what's the approach in training these GP surgeons?
Yeah.
In terms of setting the limits and giving them a wisdom on what they should take on and not. And are there any kind of experiences with kind of cowboy or cowgirl GP surgeons who go down that slippery slope and start taking on too much?
Okay, so just for people who don't know, Prince Albert is it was the first GP enhanced surgical skills program. So we call it an ESS program here, which is a fully trained GP who gets 1 year additional training. They do 6 months with our gynecologists and 6 months with our general surgeons. This program was set up by Dr. Randy Friesen in this community, and it's been ongoing for years and years. I was very skeptical when I first came here, but have very much changed my opinion, and I've been training these residents for years. I would be happy to set up another talk if you guys are interested. I am not one of the administrators of that program, but I do have 2 colleagues who would be delighted, I think, to talk to you about it. We could make this its own SWOSA meeting. But what I will say is a couple of things. you need to understand that these family medicine doctors are going to extremely small places. As Lindsay said, there are communities out there where they are the line between people living and dying. And that is not uncommon. Yeah, they're not out there doing trauma laparotomies. We don't teach them to do gallbladders. That is a general surgery thing. On the surgical side, which I can speak to more, we are training them to do primarily small procedures like umbilical hernia repairs. We do show them hernia, like groin hernia repairs, but I'd say at least half of them don't meet our criteria for actually being signed off on the procedure and able to do it in the community, because as Dr. McIver says, you've got to be doing a certain volume to make it good. And I don't know about you guys, but it took me 2 years to figure out the anatomy of the groin during my residency training, and they don't have that time. So it's very rare that we would be able to certify anyone. And usually it's somebody going to a community that has a general surgeon as a solo practitioner who can back them up and continue their training. Endoscopy wise, I actually think it's critically important for them to learn endoscopy, and they do a very good job of it. And I think they take a tremendous burden off of the tertiary centers. In the 6 months that they do with us, they do more endos, both upper and lower, than I did during my residency training. So they usually get over 150 colonos easily, over 100 EGDs, which are generally numbers that are thrown out there. They also do a lot of interventional stuff. We do not teach banding of varices. I don't even band varices up here because I don't have angio available, and it's rare that we get enough supply and equipment to be able to do it. But we do teach them to inject ulcers and to clip things and take biopsies and to lift polyps and do some of those more complex procedures. I don't know about you guys in Ontario, but we have tremendous scope wait lists. I have a 300-person wait list right now, as does every other surgeon, and the gastroenterologists are overwhelmed. So we have, for example, Nipawin that has a fully functional OR and could be doing scopes almost every day if they had the personnel to do it. We have one ESS resident that's gone out there to start his practice, and he does scopes 1 day a week. He probably does 300, 400 scopes a year, and basically takes that burden off our tertiary centers. The other thing they learn is the gynecologic side, which again is life-saving. So they learn C-sections, they learn DNCs, they learn tubal ligations. With respect to appendectomies, we do train that, but most of our residents end up not practicing that just because of a low volume. And one thing I do want to say is we are very selective of who we take into this program. We are general surgeons. We are not training cowboys and cowgirls. We make it very clear as to what they're capable of, and they are very good at determining what they're capable of. We don't send people out to the community that have no self-insight and are just going to operate on everything because they can. These are fully trained family doctors. They're not just people off the street. And we've had really good outcomes, mostly in Western Canada. We've had a few go out to the Maritimes as well. Newfoundland, there's one out there. But yeah, usually Northern Saskatchewan, Northern Alberta, Northern BC, a couple of smaller communities, Estevan, Saskatchewan, Pincher Creek, Alberta, Vanderhoof, BC. We've got one in Golden. We've got Peace River, Alberta. So I think it's a valuable program. We are never going to have surgeons that could sustain a practice in these areas. But like I said, if you guys are interested, I'd be more than happy to set it up. My colleagues have all the statistics and all the data to kind of back that up.
Yeah, so we're running out of time, and I'm going to turn things back to Dr. Brackstone for any closing comments. But I think you're right. This is an extremely complex issue, preserving our expertise versus filling needs that exist and aren't being filled by general surgeons. And I think you're right. We could talk for an extra hour about GP surgeons and where they fit in. I want to thank all three of you for joining us, and I'll turn things back to Dr. Brackstone. That was an excellent discussion, and I thank you.
Thank you, Julianne, and thanks to all three panelists. That was really a fascinating SWASA lecture, and really enjoyed Dr. Lumb's perspectives and also hearing sort of what has been and how that practice has evolved for Dr. McIver, and interesting to see it at the beginning with Dr. Glass. So wonderful overview, and obviously huge need. And it really gives us a lot of food for thought in our program. How do we maintain that expertise? But it's really nice to hear for upcoming residents who are going to have that interest in surgical career. Very impressive, and really appreciate all the work that the community surgeons do for patients. I did want to let everyone know about our next SWASA lecture, which is going to be January 27th. So there's no SWASA rounds in December. January 27th, Rich Hart is going to come and speak on elite performance, which is related to physician burnout and stress in healthcare, which we can all relate to. He's going to share his thoughts and insights on developing self-regulation. So I hope everyone has a wonderful holiday season, and we'll see you all again in January. Have a wonderful day.